Hi, my name is Brent Bowen, and I'm going to talk about the barriers and benefits of family presence during resuscitation and the improved psychological outcomes that it has on family members. So the project is, just like I said, the barriers and benefits, along with ways to implement FPDR as a hospital policy. And this is done to increase the patient family member outcomes of these patients that are undergoing resuscitation. This was done through research of different articles on the topic, along with clinical trials and qualitative analysis of patient families and ER personnel. I also created a presentation for ER managers for policy changes and a brochure for family members before resuscitation procedures. I did this research through library databases and cross-analysis of different clinical trials for their reliability. I've found through this research that there's decreased PTSD in patient families who are there for resuscitation, along with initiation of the grieving process and the ability to say goodbye. This project will recommend that hospital policy is created along with nurse education on having family present and a family presence facilitator role. My literature review was based on three foci. The first two are kind of the not opposing, but I would say they are involved in the procedures. The thoughts and feelings of the patients and how this um, initiates the grieving process and gives them the ability to say goodbye. The other would be the thoughts and feelings of healthcare professionals, why certain healthcare professionals are hesitant to have family present, and what studies say about these various barriers that they perceive. And finally, clinical trials and observational case studies just kind of talks about the different trials that were done and analysis of patient families after they were present during resuscitation compared to people who were not present, along with the family presence facilitator role and the introduction of how having a communication liaison is important to bridge the communication gap. I did this through 5 medical journals, 3 peer-reviewed articles from library databases, and 2 clinical practice guideline articles from medical associations such as the Emergency Nurses Association and uh, the American Association of Critical Care Nurses. Some of the literature review articles that I used was the Emergency Nurses Association clinical guidelines. This introduced guidelines to have that they recommend that policy should be in place for caring for family members during CPR, and common concerns of ER personnel such as distress in family, distress in healthcare professionals, and family procedural interference. AACM practice guidelines were on educational modules to bridge the discretionary gap between nurses, and this would be provided to all of ER staff and would be hospital clinical modules that would educate on how to communicate with family. And then the creation of a family presence facilitator, and this is someone who helps chaperone the family. The next one is the qualitative analysis of patient families. This was a survey of hundreds of different family members who were present during resuscitation and what they felt like, what their thoughts and feelings are on seeing their family member like that and being able to say goodbye. The first study I'm going to talk about is a study that was done in France in 2013 by Jabra et al. It studied 570 patient family members who were half of them were present during resuscitation, the other half were not. It showed that the control group who were not present during resuscitation, after 90 days, there were higher rates of PTSD, anxiety, and depression. And on top of that, over the 20 months that this project was, or that this clinical trial was done, there was less than 1% of family members who acted aggressive or tried to interfere with procedures in CPR. In addition, there was no litigation or suing going on during this whole project. Another study was an observational case study by Dr. Porter in 2017. This studied 17 resuscitation events and the difference between having a family presence facilitator present, in addition, as opposed to not having one present. It showed that whenever a family present facilitator was there, there was less ambiguity and confusion in communication between the healthcare team and the family. The objectives for this project is to improve the communication dynamic and understanding between the resuscitation team and family members, and to improve the psychological outcomes of families after they had a loved one endure CPR. The strategies to do this would be, first, implementation of a hospital policy. This would help increase provider security through policy guidelines, and it would give nurses a better idea of like a flow of what they should be following rather than just doing it along opinions. Education to nurses would be done through educational hospital modules. There was a study done in Yale New Haven Hospital of 100 ER nurses and ER healthcare professionals on their thoughts of FPDR. It was found that 77% were for FPDR, and that there would be a higher percentage if there was a hospital policy in place. And finally, there is education to families, which would be done by the family presence facilitator, and this would close the communication gap between the resuscitation team and the family. Background analysis, there really hasn't been much research on FPDR before the job risk study. Closed chest compressions were first started in the medical field in the 1960s, and since then they've pretty much kept the family separate. There was one study done on 25 resuscitation events on how families reacted, whether being present or not, and it was found that the study was canceled because the benefits were so great for the family members that researchers thought that there would be someone who would make the results, it would skew the results because someone would try to make someone present when they're not supposed to be present for the better of their psychological outcomes. Treatments is multidimensional. This means that we need to treat the patient as a whole, and doing that involves treating their family and making sure that the psychological outcomes of their family long term is on the positive side. The results I had after this this project and this research was found that there was 6 studies finding that family procedural interference was very low. The only stipulation was that there was a higher rate of doctors and nurses that were fearful for family intervention in Turkey, and that's because in Turkey they have a very there's a culture to where Turkish women will wail and beat their chests whenever they are in distress or they're grieving, and they're also known to assault and even kill healthcare professionals after their loved one died. So understandably, there is a gap here that FPDR wouldn't really work in Turkey because if family presence was always an option, there would be more. It would be a safety issue for healthcare workers. There were 5 studies for PTSD decreasing family presence during resuscitation decreases family PTSD. That's a typo. Another would be that everything possible was done, and that family members could see that everything was done. There were 7 studies, and then 4 studies for initiation of the grieving process for family members, and then 6 studies that were for the family presence facilitator role. The products that I produced was a family brochure, as you see here. This would be given to the family by the family presence facilitator before going into the room to just kind of show them, of course, they would say what is on the brochure, but this is just kind of have them a little reminder And then on the bottom there's some resources for grieving and bereavement resources that they can contact, if their family member does not make it. Outcomes. So most hospitals don't have a policy for FPDR. The AACN found that despite clinical practice guidelines and evidence-based practice, only 5% of U.S. hospitals have a written policy for FPDR, and that there was also the Porter study in 2017 found that ER nurses are more likely to have family presence during resuscitation when they're working towards the palliation of an elderly patient and assessing DNR status. And the value of the family presence facilitator is important because it gives the family members a chance to say goodbye. So the flow chart for being able to implement this FPDR would be first starting that yes, there is a discretionary gap between having family present by ED staff. This would be tackled through initially creating hospital policy. This would implement having educational modules, which would essentially close the discretionary gap and educate on the benefits of FPDR, and then the creation of a family presence facilitator. This person is an allocated member of the healthcare staff that is not involved in resuscitation procedures, and it could be utilized more in bigger hospitals where they have the patient care management role. This is somebody who's not assigned to patients, and so whenever a code comes in or CPR comes in, they don't have to hand off their assignment. They can just assume the family presence facilitator role. Short-term effects would be improved HCAHPS scores because uh, um, there's a faster response rate by healthcare providers and nurses, in addition to improved communication. And long-term effects would be decreased PTSD levels population-wide. So we talked about the perceived barriers, which were distress in families, distress in healthcare workers, and family procedural interference. We talked about the benefits, such as decreased PTSD, initiation of the grieving process, and giving families the ability to say goodbye. And finally, the most important factor for FPDR is initiation of hospital policy, educational modules, and creation of the family presence facilitator role. And so I'm just going to kind of leave you with a quote that's kind of stuck with me, and it kind of goes back to saying that we treat the patient as a whole, as far as not just the patient, but their psychological, spiritual, physical outcomes, meaning including their family. So you treat the patient as a whole, not just the hole in the patient. And here are my references. Thank you so much.